Hi and welcome back. A little while ago, I made a video talking about my past struggles with my hormones. Under that video, you left the most amazing, sometimes heartbreaking comments and a ton of questions. So I thought who better to answer those questions than the doctor who was finally able to help me with my hormones, Dr. Mathis. Hello, Dr. Bob. Thank you so much for being back.
Hello. You're welcome.
Dr. Bob, I have talked about you quite a bit in videos. You have basically saved my life. And by the way, I want to mention this. Somebody asked me if I get some sort of compensation for talking about you. I do not. I think you're an amazing doctor and you're very passionate.
This is just an informational delivery. That's all. There's no money exchange. There's nothing.
Exactly. Now, Dr. Bob, I recently made a video talking once more about the struggles I had with my hormones for a couple of years until I met you. And in that video, I talked about all the other forms of hormone replacement therapy I tried, and they didn't work for me. Then I met you. You prescribed something that worked wonders. I'm still using it. I've been using it for 14 years. Now, under that video, the question was, how come all the other things did not work for me and this works?
So hormone replacement therapy, there's about 4 delivery methods. Number 1 is pellets that go, you have to cut the skin and put the pellet under the skin, usually in the butt, okay? Potential risk of infections and bleeding and so forth. And more importantly, very difficult to regulate dose. So once they put the pellets under there, you're done. Whatever dose you get is what you get. And you may end up, I've seen women with 300 testosterones for 3 months because the person can't take the pellets out once they're in. Very hard to do that. And you don't want somebody digging around in the skin looking for a pellet. God, it's terrible. So I don't like pellets for that reason. If you're going to go on a safari to Africa for 3 months, you can put some pellets in there and take off on your trip. And that's kind of where they have a function. Otherwise, it's better to do method number 2, which is transdermal creams. Okay. Method number 2 is a little bit labor intensive for some people. Some folks just are too busy, or simply it's not their kind of delivery method. They have to work at it. They have to put them on twice a day. They have to pay attention to the timing more or less. And in some cases, if they're doing a rhythm method, they have to have the creams have to change the dosing as they go through the month. Okay, so that's a little labor intensive. The transdermal creams have several components to it. Number 1 is the crystal size. If this is a detail that you're never going to need to know it, but if I tell the women now, they may help teach the pharmacy and the doctor why it didn't work. So if the crystals are too big, they won't dissolve in the cream. So we just make up a new batch and that takes care of it. Number 2, the base cream. There's 15 different base creams. So if one base cream doesn't work, you can use a different base cream and a different base cream. This requires direct contact with your provider. You need to be in touch with them. They need to be testing on a more frequent basis. During the first 3 months, you're going to test a few times. Maybe the first 3 to 6 months, you're testing every month for the first couple of months. You're trying to figure out, are they being absorbed? If they're not being absorbed, then I've got to change the base cream and try to go that route. If that doesn't work, then I have to look for some other method. But usually there's one of those base creams, 3 or 4 different base creams. It'll work. And generally the crystal size is not a big deal, but people need to understand that's part of the picture. So your women are going to be smarter than the average for that reason. All right, so that's transdermal. Then we're going to go to the patches. Now, patches are very easy. And for a lot of people, they're great because you put on a patch, you take off. You can use the progesterone in a cream or progesterone capsules. And so, again, if you're going to use a patch, most people are okay with a patch. Some people it will not absorb. I've seen it happen where the patches don't absorb. You got to change to a different patch, that's okay, or the patch falls off. So you take a piece of tape and tape the patch on. Otherwise, it's just going to fall off. I had a woman recently who just gave up on patches, went and had the pellets, and now her hormones are all over the place because of the pellets. So patches are good for a lot of people. less labor intensive. You put it on, you forget it. You use a little progesterone. If you're going to do rhythm, you do that the last 2 weeks. If you're going to just do non-rhythm method, static dosing, you can take your progesterone at bedtime, you're all set. You can use a cream or a pill for progesterone. And then the last method, which is for the really tough cases where people just simply don't absorb through the skin. Now you got to go with oral dosing. So you give them 1 milligram of estrogen. The issue with oral is that it converts into estrone. The liver gets hit by the estradiol, immediately converts most of it into estrone. Estrone has several metabolites, one of which can be sort of toxic. That would be the 4-hydroxy estrone. And so it's probably better to avoid oral if you can, just because you've got to really detox those. And if you're not a good methylator, and I'm talking in details here, I'm sorry, but there's no reason to not talk details. They can look this stuff up and they'll understand, or they can ask questions, or they can call me and ask me questions. I have no problem with that. So if they're not a good methylator, they won't convert the hormones, in which case now they're going to have a lot of estrone metabolites around, which that's not going to happen except for a rare person, and that's an issue. So that just has to be thought about. So we got the 4 methods. The answer is, why doesn't it work? Okay, so now we get down to person specific. I have women walk in, they put on the creams, and they have textbook numbers. Everything's exactly as it's supposed to be. I have other women come in, they start the program, and their estrogen stays in the 50s. Why is that? Well, because the skin doesn't absorb it, the base cream isn't right, the patch is not strong enough, so we put a stronger patch on, or they just have skin they have great skin, and it won't go through. So that's a reason. That's not a reason to give up, though, because you can always do oral if you have to, or you can find a different base cream and add some glycerin, which is a little detail again, that will help make the hormones more absorbable. Okay? I don't like pellets, so I don't even talk about them in general, because there's no way to adjust the dose. If you want to adjust the dose, the best method is transdermal, and you can adjust the doses anywhere you want, versus patches, harder to do that. They just come in increments, and so you have to kind of pick the increment you want. And then progesterone can be adjusted. That can be used as a cream or as a capsule, either way. So yes, there are some people very tough to get the hormones to work, but that's only probably 1%, 2% maybe. Just about everybody you can get hormones to work on, but it takes communication. If you're not feeling better, you've got to get back to your practitioner. You got to send them a text, send them an email, call them up, try to make an appointment to talk to them. And depending on the practitioner, they have time or they don't have time, find somebody else. If you can't get that communication going, this is why the decision in my part was I have to be available for the women, because this is not an easy thing to do until it's up and running. So the answer is stay in touch with your practitioner and get it to work.
But I think that is quite challenging. I had a lot of women tell me if they were lucky enough, their practitioner actually put them on HRT. They never took their hormone levels once they put them on it.
Got to do levels.
They don't communicate with them. These women are still having symptoms, but their practitioner says, what? I put you on hormone. That's it. What are you complaining about?
Okay.
And it breaks my heart, because I know these women are so close to giving up, which is why I want to talk to you, because I was one of those people who was very difficult to adjust. I've seen 7 practitioners before I saw you. There is a hormone that will work for this person. There is a program that will work for this person. But like you said, they have to communicate, and they have to find a person willing to communicate and help them.
Sometimes there are other factors, not just the hormones. Sometimes the adrenals are low. Sometimes the thyroid is low. So you have to do a free T3 by tracer. We've talked about that before. And find out what the thyroid. The person yesterday, her thyroid, free T3, is 1.0. The range is 1.8 to 4. So she's way below on her thyroid. And number 3, sometimes people have viral infections. They have CMV, they have Epstein-Barr, they have chronic fatigue. There's other reasons that they don't feel good on the hormones. So therefore, you have to have a practitioner who wants to kind of dig into it a little bit and try to figure out, we got the hormones set right. we got the adrenals, we got the thyroid set right. How come you don't feel good? Now you got to go look for something else. But just keep that in mind that in a very small percentage of people, you have to look a little deeper into other. I mean, Lyme disease. You can have that. There's other. I have a woman right now, and she said, "I'm tired," and I said, "Well, how long have you been tired?" And she's been around for a year. I said, "Well, how long have you been tired?" She says, "Oh, 10 years." I said, 10 years? Did you tell me that in the beginning? No. I said, well, okay, so there's something besides hormones that's going on here. This is why you've been tired for 10 years. We have to start looking.
But you know this because you actually test women's hormones. When I got on the program you put me on, after 1 month we tested, after 3 months we tested.
Oh, you got to test.
I mentioned, some of these doctors, they give these women hormones and then they'll never talk to them again. They don't test their hormones. They don't know did anything even happen.
Right.
So that is very important to have your hormones tested and see where they are.
There is a solution. Thyroid. What I can do is I can send you my online list of labs. Okay. And there's about 7 labs on this online list. So women can go get tested independently without their doctor.
That's awesome.
You could actually order the tests. In fact, it's even cheaper. So now I'm kind of directing people to, if they don't have good insurance, let's go over here to Life Extension, or let's go to Request a Test, or let's go to whatever, and let's get that website to do the test for you for like $70, $30, $40. And now you test yourself.
That's awesome.
And you find out what's going on.
Below.
Then you can communicate with your practitioner and say, here's my test numbers. What do you think? And hopefully there's going to be a response from that. And then it doesn't hurt to change practitioners. Sometimes, that's just not their forte. They're good at other things. They're not good at hormones. They're not as comfortable with hormones. Find somebody who is. Find somebody, whoever, wherever, and work with them on the hormones.
And I think that's so important. Find somebody. Do not give up. I have some people, well, I tried, and I think like that woman you talked about who's been tired for 10 years, we get so used to this lower energy and not feeling good. They're like, oh, this is just how it is now. But life is not worth living like that. We need energy and we need to have that oomph. So don't give up, find another practitioner.
Right. You just have to, don't give up. Hang in there. You got to find somebody that can get it adjusted for you, give you enough of whatever to make the numbers come up where they belong. And you can test yourself. You don't need the doctor to help to order a test for you. So I apologize to all the doctors out there, but I have some patients that are very aggressive and they test themselves, and I'm okay with that. I don't have a problem with that kind of with women doing that or people doing that. I'm okay. Some physicians, they don't like it. They want to be total control. I don't need to do that. I just want to get along and get things to work so they feel better. That's what I told this last time. I said, look, I didn't know you're tired for 10 years. We have to look at other things. We have to do a Lyme test. We have to do some other types of testing.
Now, this is what I love about you, because you look at the full picture. But talking about the full picture, is it ever too late to go on hormones? In other words, let's say I go in menopause at 50 and then I'm without hormones for 20 years. At 70, I decide I've had enough. I feel like crap. I want to go on hormones. Is that too late? Can that woman then, after being 20 years of no hormones, go on hormones? Are there any risks for her doing that? Any disadvantages, or are there benefits for her doing that?
Okay, so the answer is, in my practice, the answer is no. She can go ahead and start hormones, but you have to start very slowly because the system hasn't seen it for 20 years. So you start with very low dose and take months, several months to get up to a reasonable dose. Typically, the problem with practitioners is that they'll put people on standard doses who haven't seen hormones for 20 years, and then they have a lot of symptoms because the doses are too strong, too quickly, too strong. Okay, so that's number one, is start very, very slow. In terms of risk, I use bioidentical hormones. If you use synthetic progestins, there is some risk. This is why the birth control pill for women over 35 is known to have some risks of blood clots and strokes. So don't smoke if you're over 35 and you're taking birth control pills. And Recently, about 4 years ago, there was an article that came out that stated that birth control pills can cause cancer. Well, I don't know about that, but the answer is it's synthetic progestins, synthetic estradiol. Now, in some of the studies that have come after the turn of the century at 2000, 2001, synthetic estrogen was proven not to cause cancer. Synthetic progestins was shown to cause cancers and strokes. So I just avoid the synthetic progestins. So as far as it's okay to start hormones at any time in my world, I'd like to do a complete workup and see what's going on. I do coronary calcium scores. I make sure that women don't have a lot of plaquing in the heart. And then we do general integrative holistic kind of approach to make sure they don't have diabetes and see if they have an exercise routine. In other words, put a person back together. You're going to put them on hormones, make sure that everything else is working, and start really slow. Go low dose, slow, bring the dose up slow. You can tell because the breast tenderness tells you right away if you're going too fast. And you just have to back off.
But do you see benefit in older women going on hormones after not having been on
So,
them for a long time?
I had a person come in last week, and she's just about the case. She's about 68, and she was telling me how she's not been on hormones probably for 12 or 14 years, whatever, since she had them for a little while and then quit. Then she shows up in the office 7, 8, 10 years later and says, "Okay, I'm having some trouble with word finding. I'm missing words. I'm talking to somebody and I can't remember what I want to say. So I want to try the hormones to see if I can fix that." So that's the answer is, yeah, that's why she's there. And we're going to give her the hormones, and then she's going to tell me in the next 2 or 3 months, she's going to say, yes, you know what? It's better for me. I now have words I was losing. I'm now more functional. I'm sleeping better. So therefore also that helps reduce stress and helps with the word finding. So that's exactly why she actually came in, because of the cognitive decline.
So if there are symptoms, then that is definitely beneficial to them still.
Now, the other thing we need to talk about briefly is Dr. Brednison has a book called End Alzheimer's. And in his book, there's a section on hormones. So you want the brain to work. You want to optimize brain function and avoid the depths of Alzheimer's. His recommendation is to be on HRT. We're talking women in their 70s and 80s, because those are the people who are heading toward Alzheimer's, or people who have genetic tendency. And this is Dr. Brednison from Stanford, who basically did the research, figured out how to get people back from Alzheimer's. And he's done a great job. And a lot of people follow his program, including myself.
That's incredible.
So there's an argument for older people to have HRT. Doesn't have to be a high dose. You don't have to have crazy doses. But just having HRT is better for the brain because estrogen manages the mitochondria in the brain. I went to a research group in UCLA probably 12 years ago, and this woman researcher came in. She's about 55, and she said, "I'm always going to be putting a little bit of estrogen on my wrist every day for the rest of my life because I've proven to myself with my research that it helps the brain work."
Not just the brain, but it keeps our bones strong. It keeps our heart healthy.
All the muscles better toned, skin more fluffy, get rid of the wrinkles. Collagen vascular tissues, all those connective tissues are healthier. The hormones have receptors all over the body, and those receptors respond to estrogen, and it doesn't take a lot. Even a little is better than none.
Now, what do you say? I've had quite a few women tell me, so the doctor actually did put them on hormone replacement therapy, but they have been on it for 5 years, and now the doctor wants to take them off because of the risk of cancer. What do you say about that?
Okay, so if we're going to talk about cancer, then first thing I want to point out is that young women from age 20 to 45 have what I describe as raging hormones. Their estrogen every month is going like this, cycling up to as high as 285, 385 by themselves without even taking any hormones. I had a woman come in who was 49 years old. Her estradiol was 385. Her progesterone was like 19 by herself
Good for her.
at day 21. This was a very fertile, healthy 49-year-old person. There's no cancer there. If you take a look at a pregnancy, what happens in pregnancy? I had one woman, she said, well, I missed a period. I said, I'm not sure what's going on. I said, let's just get an estrogen level and see. Well, her level was 3,000. Her estrogen level was 3,000. She was 46 years old and pregnant. And there's no cancer there, because cancer, if a pregnancy was going to cause cancer, then all the pregnant women would die and the babies would have nobody to take care of. Mother Nature's not going to do that. And I was in a lecture once with Dr. Ben Lynch about genetics, and women in menopause, their pathways are different. Metabolic pathways function a little differently than women who have hormones. And that difference produces inflammation with that 4-hydroxyestrone we talked about. And that inflammation apparently over time can lead to problems such as cancer. So I think really the issue has been confirmed by some studies around 2001 where they've showed that, in fact, Dr. Taguchi, who's an oncologist in Santa Barbara, has a study of her own running. She's been running it for years. She's got about 150 plus people in this study, women who had breast cancer, who then started hormones, again, right after the surgeries, women who had breast cancer who didn't start hormones. And in this small study of hers, even there, she was able to prove that women who start hormones had fewer recurrences of cancer than women who didn't, probably because of that inflammatory factor. Hormones, if you take a look, I had a male person had prostate cancer, and they decided to completely obliterate his testosterone. They wiped out his testosterone chemically. He died in 6 months. And over the next 6 months, you could watch him cognitively just go right down so far he could hardly talk. And neurologically, he had trouble walking, and then he just died. I mean, almost a surprise to me. So there's a man without testosterone, women without their hormones.
It's the same with men. Men get prostate cancer when they're older, when their testosterone is non-existent. If testosterone would cause prostate cancer, they would have it when they're teenagers, when
they would have it as young men. And so there's a doctor in, I'm trying to remember his name, who proved that. And he basically uses testosterone on men with prostate cancer. And it doesn't extend the cancer. It extends their life, but it doesn't extend the cancer. So these are really difficult issues, and it's personal choices, and it depends on how you want to feel. And you work closely with your physician, and anything can happen. People have genetics. Genetics is the bottom line. If they don't metabolize glutathione very well, if they're not very good at antioxidation of their bodies, there's more risk of things happening to them, other diseases and so forth. Dietary, lifestyle, genetics, all these things have an impact on whether somebody gets a cancer or gets sick or has diabetes. It's less likely to happen with people who are taking hormones, because hormones produce health and revitalize tissues.
So taking women off after 5 years is all based on an outdated fear that has really never been proven. In fact, as you said, the opposite has been proven.
I don't really know. I've heard that. I haven't read the study. I haven't read the material to see exactly why they decided that, and why these. I don't see it as a benefit, and I have so many people who do so much better, who've come in as I've described. Some people come in like this woman this week. She's there because her brain isn't working as well as she wants it to. And that was literally the reason why she wants to go on hormones. And she's read enough about it and said, okay, I want to try this and see how I do. And the answer is she'll do a lot better. And sleep. Estrogen works on the enzyme that breaks down serotonin. So if you have estrogen, you block the breakdown of serotonin, and so therefore it reduces depression in women. which is why they end up giving them antidepressants when they're in menopause, because they've lost the natural tendency to keep the serotonin up, which is the estrogen blocking that enzyme. So the answer is, each person has to decide for themselves what they think they should, and then find somebody that they can talk to and try to make a clear understanding of what they should do about their symptomatology. And, you know, it's not the same for women and men. Men have testosterone until they're in their 70s. Women don't have hormones past 40, 45, or 50. And it's dramatically changes their relationship with their husbands, their families, their sleep, their overall wellness, their emotional quality of life. I mean, it's just, I've seen it so, well, I just see it, that's all. I mean, it's just there. And when you treat these people, the husbands call up and say, thank you for giving me my wife back.
I can imagine. Well, I so appreciate everything you do for women, Dr. Mathis. If it wasn't for you, I don't know what I would have done. So thank you so much for your passion, for all your research. And thank you for being here.
Okay, we'll talk some more.